Falcon Review for Pathology for USMLE Step 1. The topic for this section is breast pathology. There are various disorders of development that can affect breast tissue. Supernumerary nipples or breasts simply result from the persistence of epidermal thickenings along the milk line, and it can extend anywhere from the axilla to the perineum. Accessory axillary breast tissue, this can extend over the entire anterolateral chest and over even into the axillary fossa. For women, congenital inversion of the nipples is a problem when it impairs nursing of infants. And finally, macromastia can lead to chronic back pain in patients. This can be due to body habitus, or the macromastia can be due to tissue response to the various hormonal changes that occur during puberty. Inflammatory conditions of the breast are often referred to as mastitis. Acute mastitis often occurs during nursing, generally in response to infection with organisms such as Staphylococcus aureus, and is seen clinically by the presence of cracks and fissures of the nipples. Generally, it tends to be unilateral, affecting one breast versus the other. It presents as a localized area of inflammation, which, like in other areas of inflammation in the body, will be characterized by redness and soreness. The sequelae that one wants to avoid here is the development of an abscess and the infection spreading any further within the breast or surrounding tissue. Other breast inflammation syndromes include conditions such as mammillary duct ectasia, focal necrosis of the fat tissue within the breast, and granulomatous mastitis. Mammillary duct ectasia generally occurs later in life, in the 5th or 6th decade. You often will see it in women who have had several children or who are considered what we call multiparous. The presentation here is one that often can be confused and be concerning for a more malignant tumor of some type, as there will be a palpable periolar mass with skin retraction, similar to the peau d'orange effect that one would see with different tumors. The patient will also present with a thick, cheesy secretion of the nipple, which will also be concerning for the possibility of a tumor. Focal necrosis of the fat tissue surrounding the breast can often occur secondary to some sort of trauma to the breast. What occurs here is hemorrhage within the early stages following the traumatic event, followed by central liquefactive necrosis of the surrounding fat. Now remember, when fat undergoes necrosis, one of the corresponding events that often occurs is a form of calcification. And thus what these patients can end up with is an ill-defined nodule of gray-white firm tissue containing small foci of chalky white or hemorrhagic debris. The chalky white debris due to the fact that when one looks at the tissue microscopically, you see the deposition of calcium secondary to the liquefactive fat necrosis. This can lead to very concerning findings on radiographic exam, and again, the concern that the patient has developed a tumor. Finally, granulomatous mastitis can be due to a variety of conditions, including systemic granulomatous disease, conditions such as Wegener's granulomatosis or sarcoidosis, which may involve the breast as well as other organs. One can also see it with infections. And when one is thinking of infections and granulomas, obviously the primary candidate that should leap to mind is Mycobacterium, although various fungal infections can also produce a granulomatous response. Now, in terms of looking at tumors of the breast, we'll begin by considering the various benign tumors and conditions that can lead to women being biopsied out of concern that they have developed a more malignant tumor. Now, very briefly, just to deal with the radiographic signs that lead to a concern for breast cancer in patients, the various things that one may see, the most simple is simply a mass. In the otherwise hypodense area around that makes up the breast tissue, one can see, as demonstrated in this radiograph here, the presence of ill-defined, denser masses that may contain a tumor. Ours is outlined here by the arrows on either side. Architectural distortion of the breast tissue, that is another sign that is concerning for breast cancer. And finally, calcifications. Remember that calcifications, however, can be produced by conditions other than breast cancer. We mentioned one of these just a few moments ago with the liquefactive necrosis that can occur in the fat tissue of the breast following events such as trauma. Now, one of the most common conditions that you will deal with in patients who come to you with concerns about a particular breast mass is fibrocystic change. This is frequently seen in patients within their reproductive years between ages 20 and 40. The pathogenesis is somewhat unclear, although it is considered that this condition results from various hormonal imbalances, and it has been noted that oral contraceptive use actually appears to decrease the risk of patients developing fibrocystic changes. The clinical features, unfortunately, can lead to the patient and physician being concerned that the patient has developed a more malignant condition of some type. There can be palpable lumps produced. There can be mammographic densities or calcifications, such as you saw in the radiograph that we showed a moment ago, and there can also be a nipple discharge, conditions that can all be concerning and possibly signs of, again, a more malignant condition, hence the need for the patient to undergo a biopsy. Now, when we refer to fibrocystic change, we're referring to a range of morphologic changes, and thus one must be very clear when talking with one's pathologist about what particular changes they are seeing within the biopsy, and do these all fall under the heading of fibrocystic change, or do some of the changes herald a possibly pre-malignant condition of some type. Most often, when we're dealing with fibrocystic change, the pathologist will be referring to morphologic features such as fibrosis, various cysts that may or may not contain fluid, and epithelial changes, especially things such as apocrine metaplasia. What you see here in this H&E slide, taken from an example of fibrocystic change, is dilation of the ducts, and particularly the one that is to the right side of the slide, that produce microcysts of various size and shape. Another very common benign tumor of breast, and the most common benign tumor, is the fibroadenoma. As the name implies, this tumor is composed of fibrous and glandular tissue. And one thing to note when you're looking at the clinical histories in questions dealing with breast masses that you'll see on USMLE Step 1, think about the fibroadenoma if, within the history, they're talking of a patient who is under the age of 30, as this is the age group in where you will most commonly see the fibroadenoma. Again, it must be stressed that this tumor is the most common benign tumor of the breast. The pathology tends to be somewhat specific. On radiographs, you will see a spherical nodule that is sharply circumscribed. That is one characteristic that delineates it from the more invasive malignant tumors, and one that is also freely mobile. Again, another characteristic that delineates it from more malignant tumors, which tend to produce sclerosis and hardening of the surrounding breast tissue. You frequently see fibroadenomas in the upper outer quadrant of the breast, and they have a grayish-white appearance when removed and examined macroscopically. This radiograph simply gives you the example of what one might see on a mammogram looking at a fibroadenoma. Note the clearly circumscribed white mass here within the breast. If one were to examine that in a breast exam, one would hopefully find that it is freely mobile as well. Large duct papillomas tend to be solitary lesions found within the lactiferous ducts or sinuses. More than 80% of these tumors present a spontaneous unilateral serous bloody nipple discharge, again a finding that can be concerning for the patient having a more malignant condition. These large duct papillomas are rarely more than 1 centimeter in greatest diameter, and if solitary tend to be benign. However, if one is dealing with a patient with multiple small duct papillomas, they do appear to be, according to the literature, at increased risk for cancer. This slide simply shows an example of an intraductal papilloma demonstrated by the arrow at the bottom of the slide. What we're seeing here is a cross-section of a lactiferous duct with the solitary papilloma located at the base of the duct. If we were to take a closer look at that papilloma, we would see that it has the sort of typical features that one associates with a papilloma, a somewhat finger-like or frond-like structure to the overall mass. This now brings us to the malignant counterpart of the various benign tumors that one sees in the breast, the topic of breast cancer or breast carcinoma. The current incidence is considered to be 1 in 9 women in their lifetime will develop breast cancer. It is a rare condition in patients before the age of 25 unless there is a family history of breast and possibly ovarian carcinoma, the familial syndromes with mutations in the tumor suppressor genes such as BRCA1 or BRCA2. However, in patients who have the non-familial form of breast carcinoma, the average age of presentation will be generally around the mid-60s, age 64 or so. Breast cancer, unfortunately, is the most common cause of breast masses in postmenopausal women, and like the fibroadenoma, is frequently found in the upper outer quadrant. The genetics of breast cancer, particularly with the completion of the Human Genome Project, are becoming better and better delineated. As I'm sure you're all aware from the news from several years ago, we have discovered 2 tumor suppressor genes that are involved in the development of breast cancer and possibly ovarian cancer as well, BRCA1 and BRCA2. One can also see breast cancer in Li-Fraumeni syndrome. These patients often develop multiple tumors, with breast tumors being one of the many that they will develop over the course of their lifetime. And finally, patients who have mutations within the p53 tumor suppressor gene are also prone to the development of breast cancer. Other risk factors for the development of breast cancer: family history, we mentioned earlier, particularly the development of breast cancer in first-degree relatives, mothers, aunts, sisters, etc., will put a patient at greater risk for the development of breast cancer. There has been great debate in the literature and in the lay literature about the role that hormones, particularly those present in oral contraceptives, may play in the development of breast cancer. We do know that obesity increases the risk of breast cancer due to the increased estrogen synthesis in fat. There's increased risk for the development of breast cancer with carcinoma of the contralateral breast or endometrium. Also, patients who undergo early menarche or late menopause also appear to be at increased risk for breast cancer, and those patients who have not had children or who are what we term nulliparous. Those patients who wait to have children and have them after the age of 30 are also at increased risk for breast cancer. There is apparently at least a small risk associated with exogenous estrogens, particularly those given without any corresponding progesterone. In terms of histologic changes that may be a prelude to the development of breast carcinoma, you will want to be on very good terms with your pathologist to make sure that they are aware of the role that atypical ductal hyperplasia plays as a risk factor for the development of breast cancer. And thus one will need to read your pathologist reports very carefully to ensure that your pathologist is looking for this in a background of what may be otherwise benign changes, such as fibrocystic change. Thus, if one receives a report which says that the patient has not just fibrocystic change, which we tend to consider to be benign, but ductal or atypical ductal hyperplasia, one will want to consider that patient to be at increased risk for the development of breast carcinoma. Now, there are various forms of carcinoma in breast that we refer to as in situ carcinoma, similar as what one has within the development, for example, of carcinoma of the cervix. Here what we're referring to is a cancer which is affecting a duct or lobule, which has not moved beyond that actual duct or lobule into the surrounding tissue, say invading the surrounding supportive tissue or adipose tissue. Given the 2 major components of the breast being the ducts and lobules, it's not surprising then that one can have ductal carcinoma in situ or lobular carcinoma in situ, and we will touch upon each of these briefly. Then there are various forms of invasive carcinoma, the most common of which is ductal carcinoma. Lobular carcinoma is a unique entity which carries particular risk for the patient involved, and so we will deal with that separately. And then there are various subtypes of breast carcinoma which may carry better or worse prognoses depending on the type of carcinoma involved. This ranges from tubular, or what's often referred to as cribriform carcinoma, to colloid or mucinous carcinoma, medullary carcinoma, and papillary carcinoma. To deal with the in situ forms or non-invasive forms of carcinoma first, ductal carcinoma in situ refers to a malignant population of cells that lack the capacity, as we said earlier, to invade through the basement membrane. However, when one looks at the ductal acini, you see that they're distorted and unfolded and take on the appearance of small ducts. Now, there are various subtypes of ductal carcinoma in situ that are characterized by different histologic features. Comedocarcinoma is one that is characterized by the very unique feature of a central area of necrosis and solid sheets of high-grade malignant cells. These punctate areas of necrosis can take on a comedone-like appearance. If you have a comedocarcinoma, ductal carcinoma in situ, there must be, therefore, a non-comedo ductal carcinoma in situ, here simply made up of monomorphic cells that may or may not have small areas of central necrosis. In general, if you are reading a problem and they refer to an area of carcinoma in situ that has necrosis, you want to think about the comedocarcinoma, ductal carcinoma form. Cribriform ductal carcinoma in situ has ductal carcinoma spread evenly through the intraepithelial spaces. The papillary form of ductal carcinoma in situ is exactly what the name implies, the development of ductal carcinoma within papillary or small finger-like projections of atypical cells. And then micropapillary DCIS simply demonstrates itself as bulbous protrusions surrounding a fibrovascular core, classic sort of papillary-type histologic appearance. Ductal carcinoma in situ affects the nipple is referred to as Paget's disease of the nipple. This is DCIS that extends from the nipple ducts into the contiguous skin of the nipple and areola. Here, the nipple and areola are often fissured, ulcerated, and oozing. One can imagine that this would produce a similar clinical picture of pain, erythema, and discharge. If you remember back to the various benign or infectious conditions that we talked about that can produce a nipple discharge, you can understand the need for biopsy to try and determine in these patients, is this discharge secondary to an infectious or benign condition, or is it due to a premalignant condition such as DCIS? Lobular carcinoma, as demonstrated in the slide here, is manifested by the proliferation in one or more terminal ducts or ductules of this monomorphic population of atypical cells. One particular histologic appearance that these cells can take on is that of a signet ring cell, similar, for example, to the sort of signet ring cells that one might see within some of the more classic GI carcinomas, such as one might see within the stomach. And then one difficulty in trying to determine if lobular carcinoma in situ is present is the fact that in terms of gross morphology, there is rarely distortion of the underlying architecture. And so one may not have any overt signs that lobular carcinoma in situ is actually present. Now we move on to the topic of invasive carcinoma. Invasive carcinoma, when present, tends grossly to give a picture of dense, fibrous, hard tissue stroma that it can or cannot be sharply delimited. Often the nodules of invasive carcinoma will be anywhere from 1 to 2 centimeters in diameter. There can be infiltrative attachment to surrounding structures with invasion of the chest wall, dimpling of the skin, and retraction of the nipple, that peau d'orange effect that one hears described in cases of invasive carcinoma that affect the areola and nipple. Compare what you might expect the radiographic appearance of invasive carcinoma to be compared, say, to that of a fibroadenoma. Remember, we described a fibroadenoma as being sharply demarcated, round, and freely mobile. Invasive carcinoma, on the other hand, will tend to be firmer. As it invades the surrounding structures, the cancer itself will not be freely mobile, and the architectural distortion created by invasive carcinoma will be greater than that of a fibroadenoma, and your borders will not be with invasive carcinoma as sharply defined as they would be within a benign tumor. Thus, when one is looking at a radiographic description of a mass within the breast, be on the lookout for architectural distortion, borders that are indistinct, and any dimpling, retraction of the surrounding skin, and any mass that is described as hard or is not being freely mobile. This slide here simply shows a portion of a specimen of an invasive ductal carcinoma. Here, the tumor has moved in the surrounding breast parenchyma and fat. Note the appearance of retraction of the surrounding tissue as the tumor infiltrates in the surrounding breast substance. You can imagine that this would not be, again, as freely mobile or as distinct in terms of its borders as something such as a fibroadenoma. Now, invasive lobular carcinoma is, as we indicated earlier, a distinct entity which presents both the clinician and patient with a series of slightly different concerns to that of invasive ductal carcinoma. For one thing, invasive lobular carcinoma tends to be bilateral. Hence, if one finds it within one breast, one needs to be concerned about it being present in the other, even if the patient does not have any complaints of a mass or other signs or symptoms within the contralateral breast. It tends to be multicentric. Hence, if one does a biopsy or a lumpectomy and finds lobular carcinoma, one cannot be sure that one has removed the entire tumor, as it may be possible that there are other foci of the tumor elsewhere in the breast or in the contralateral breast. The lobular carcinoma will often have a diffusely invasive pattern, and when it metastasizes, it likes to go to the CSF, the ovary, uterus, and to the bone marrow. Other particular forms of invasive breast cancer that's worth knowing about are tumors such as medullary carcinoma, which tends to have an association with mutations within the tumor suppressor gene BRCA1. These tumors, when seen grossly, are described as having a soft, fleshy consistency, which is somewhat different from the typical invasive ductal carcinoma, which tends to give a harder, more grittier appearance. Also, in comparison to invasive ductal carcinomas, medullary carcinomas will often be well circumscribed, a feature one might expect of a more benign tumor. Poor prognostic factors here will be findings such as a high nuclear grade, that is a high nuclear cytoplasmic ratio or extensive nuclear atypia in the cells that make up this tumor, aneuploidy when one does a chromosome analysis of the tumor, absence of the hormone receptors for estrogen receptor and progesterone receptor, abnormal expression of p53, or a high proliferation index, or what we might refer to as a high mitotic rate when these tumors are examined under the microscope. One other classic feature of medullary carcinoma is the presence of lymphocytes surrounding the edges of this tumor. As you see in this slide here, the tumor occupies the right-hand part of the slide. The darkly eosinophilic atypical cells surrounded by sheets of lymphocytes that come around this mass of infiltrating tumor cells. Prognostic factors in general for breast cancer, the major concern that you will have as a clinician is the presence or absence of lymph node metastases. The status of the axillary lymph nodes is considered the most important prognostic factor in dealing with patients who have breast cancer and undergo a lumpectomy or mastectomy. Invasion of the skin or surrounding skeletal muscle is a bad prognostic sign. Tumor size is also important in terms of the prognosis for these patients. And then the particular histologic subtype can also be a better or worse prognostic factor for the patient. Tubular and colloid carcinomas in particular are considered to have a better prognosis than other forms of breast cancer. Tumor grade is also important, and hence you will be relying on your pathologist to make an accurate determination based on features such as the nuclear grade, the formation of tubules, and the overall mitotic rate in the tumor. The presence of estrogen and progesterone receptors allows the patients to be treated with the newly developed estrogen therapies such as tamoxifen. Again, the proliferation rate, the presence or absence of mitoses, and the number of mitoses present is a prognostic factor. And finally, the overexpression of the HER2/neu oncogene. Patients whose tumors overexpress this are considered to having a worse prognosis.